So our first speaker is Professor Chris Blyth from the University of Western Australia. And Chris is widely regarded around Australia as one of our foremost experts in RSV. Chris is a paediatric ID physician at Perth Children's Hospital, and he's also a clinical microbiologist with PathWest and director of the West Farmers Centre for Vaccine and Infectious Disease. He does a lot of research in basic clinical and applied research, looking at childhood infection and particularly acute respiratory infections. He's also been a member of the Australian Technical Advisory Group on Immunisation and co-chair up until 2021. And heavily involved also in the ATAGI COVID-19 working groups. So I'll head over to Professor Blyth, who's talking about RSV epidemiology and future treatment strategies. Thanks, Chris.
Thanks very much, and thank you for the invitation. Fantastic to come to you this evening from Perth. I've been asked to talk on a topic that 6 months ago I probably could fit into 25 minutes, but there's been an absolute explosion in the information to present to you. So I'm going to try and cover as much as possible. I apologise if I run over. I'll move relatively quickly, but I'm happy to pick up any elements in the question times, and my email is there. So RSV epidemiology and future prevention and treatment strategies. But before I jump into that, I'd like to acknowledge that I'm on traditional lands. For me, that's Noongar Wujak Wujja. Pay my respects to elders past, present and emerging, and also thank the organisers thank you for giving me a talk that's not COVID. I've been banging on about COVID for about 2 years now, so I'm really pleased to talk about another respiratory pathogen that clearly is important, not just as a paediatrician, but I think actually is increasingly important to geriatricians as well. I can't help but being a microbiologist, so I'll lead with the virus that we're talking about. So I'm talking about RSV. It's a pneumovirus and in two important strains, A and B, and the two key virulence factors are G and F glycoproteins. And this is really important when I'm talking about prevention and treatment strategies. And the G and the F protein are both important for adherence and penetration, but also key targets for an antibody response. And both humoral and cytotoxic T-cell mediated immunity is vital for the pathogenesis of this disease. I'm going to show a very simple pathogenesis slide, but I'm going to loop back to this. And the reason I show this is clearly impact of the virus, transmission and cytopathic effect is one thing, but also the immune response and an abnormal immune response are relevant to the pathogenesis of this disease, and I'll come back to this at the very end of my talk. Now, for most people perceive as RSV as a mild disease of young children, but I'm going to present over the next 5 minutes data that I actually think it's actually a much more severe disease, and it's a disease of all populations. And to lead out with that, global burden of disease data suggests that about 20% of deaths in children under the age of 5 are due to lower respiratory tract infection, and actually RSV is a major pathogen in there. And if you put that together, you're talking about 200,000 RSV associated deaths annually, of which almost all occur in low and middle income countries. We've compiled these data in a systematic review of 180 studies, and it really shows that of those children with community-acquired pneumonia, RSV is the most important pathogen. So about a quarter of community-acquired pneumonia cases globally have RSV detected. Now, a lot of these data come from developing nations, but actually if you look at in Australia, the numbers are remarkably similar. So data from a case control study that we performed in Perth over a number of years looking at pneumonia, and very similar. So RSV is found in 1 in 5 children with an attributable fraction of about 20%. So RSV is a major driver of low respiratory infection in children. If you look then at actually the burden of disease, it is clearly skewed to young children. This is a study we did over 12 years looking at laboratory data linking to administrative data, and it highlights that the rate of infection in children under 3 months is about 3% per year, dropping to about 1% in older infants. Clearly an underestimate given that only 50% of children hospitalised with an acute lower respiratory tract infection are tested for a respiratory virus. And although bronchiolitis, which is a clinical diagnosis, is the predominant clinical phenotype in the very young, in older children it is really quite varied, from pneumonia to upper respiratory tract infection and croup. But there is clear global awareness and increasing global awareness that RSV is a major driver of hospitalisation for young children, both in the Southern Hemisphere and in the Northern Hemisphere. But alongside of that, I think there's emerging data to demonstrate that actually it is a significant burden of disease in adults as well. Anne Falsey's really led this charge, and this old study from Rochester really sparked interest in RSV in older populations. And in summary, it demonstrated that RSV infection occurs annually in about 5% of healthy elderly and high-risk adults. And if you look at hospitalised adults, RSV is up there with flu, resulting in similar length of stay, similar ICU admissions, and similar mortalities. Others have tried to model that internationally. So these are data modelling study done by Uni in New South Wales. And the reason I show this is that it actually shows this U-shaped curve for RSV, where infants and the elderly are at greatest risk, and really starts to put some population estimates. So it's likely there's about 12,000 RSV admissions per year, and that's in a similar modelling study about 20,000 flu admissions. About half of these are in adults. I think there's an opportunity to really understand RSV epidemiology in the elderly from this point onwards. These are data we have locally from Western Australia, looking at adult and paediatric RSV and flu hospitalisations. And the reason I put these up is we've had a similar testing algorithm in children and adults over this period of time. The red line here is RSV and adults. And as many centres move to more broad-based multiplex PCR, we'll have a much better understanding of the importance of adult RSV in our population. And I think this is integral to inform treatment and prevention strategies in the future. There is a burden of disease that is underappreciated, which is potentially preventable. So in summary of this thought is RSV is common, an upper and lower respiratory tract infection in all ages, in all countries, and a range of severities. I do believe we need to better understand adult RSV type, and now's the time to do it, particularly as we're testing more in the COVID environment. And it's likely, given that burden of disease both in children and adults, that even a moderately effective prevention and treatment strategy could have major impacts on disease. When I trained, RSV was a seasonal disease. It occurred every year, and importantly at the same time of year. In Western Australia, it was always May. Each year we'd really kick off with our RSV season, and our respiratory wards would fill with children with RSV. It's likely that RSV has been seasonal for centuries, but as we've demonstrated in recent time, that's not always the case. This is a modelling study where we've tried to develop a risk prediction model to look at the true burden. The reason I highlight this is really to demonstrate that seasonal pattern of RSV. These are data from 2000 to 2012, and both the true data in blue and the predicted RSV is incredibly seasonal with this short, sharp winter peak. COVID clearly has changed that. So we first reported in early 2021 our unseasonal RSV activity. So importantly, both RSV in the top panel and flu in the lower panel were absent in Western Australia over the normal winter period, and the black line in both of these plots is our normal winter peak. Borders closed in Western Australia in March and remained closed over that period of time. And so we thought we'd skip a year until the summer peak that occurred starting in November, increasing in December and peaking in early January in 2020, with very similar peaks occurring the same year. So the seasonal aspect of RSV was all turned about. And although we thought this was unique to Western Australia at the time, it has been replicated both in the Southern Hemisphere and in the Northern Hemisphere, these summer RSV peaks. Trying to explore why was a great way to collaborate with New South Wales and Victorian collaborators in here, and this shows you the panel of RSV activity in the red bar in New South Wales, Western Australia and Victoria. And importantly, those peaks are timed around when community activity was starting to open up. So a delay in Victoria, particularly with their longer lockdown in 2020. But the genomics actually are really interesting here. So the genomics show that actually there was two distinct clonal clusters that emerged, both in Western Australia and also on the East Coast, distinct from each other. And we thought they were going to be new introductions that really came into a ripe environment. But actually looking back, they were present pre-COVID, had amplified locally, and then really circulated in the naive population at the end of 2020, beginning of 2021. So really giving us unique insights into RSV activity. So although traditionally seasonal, it has become unpredictable and unseasonal, and COVID, the true disruptor that it has actually forced us to question many of the assumptions that many of us in this field have made about seasonality and transmission. And I think this is important, particularly as future control strategies may need to be implemented in a seasonal fashion. So understanding the epidemiology and the predictors of the epidemiology will be key to their use. Well, let me jump into, is it inevitable or is it truly preventable? And although RSV prevention strategies have long been held as something of the future, I think we're closer than we've ever been at this stage. This is a pathway showing the vaccines and monoclonals in development at the moment. And as you can see, there's a huge range for different companies in the preclinical phase 1, phase 2 and phase 3 space. Prevention strategies have often focused on, one, maternal vaccination to try and achieve transplacental antibody to protect the young infants, monoclonals, particularly in younger infants, and importantly, elderly programs as well. And I'm going to try and show you data from these three programs. But before I do that, I think I need to highlight an important component of RSV, that it's really the discovery of which has really allowed this to move forward. The F protein changes conformation when it binds, so we have a pre-fusion and a post-fusion conformation, and this has been really important as far as identifying likely sites and likely drugs to target those. I'm going to first talk about monoclonal antibodies, and success has been demonstrated by palivizumab and nirsevimab, and I'm going to talk about those. Palivizumab is a drug that's been available for nearly 20 years. So this study performed nearly 25 years ago demonstrated that a humanized murine monoclonal antibody, which really was directed against the fusion glycoprotein, was highly effective at preventing disease. So a 55% reduction when used in a specific population. And this trial population was preterm babies born before 35 weeks or those with underlying lung disease like bronchopulmonary dysplasia. So a 55% reduction. But the real challenge with this drug has been monthly injections and incredibly high costs, so much so that its utility has been restricted globally at this stage and really hasn't been implementable at a broader population. And so there has been a desire to develop more broadly available and broadly active monoclonals. And Siptavimab, I'm not very good at saying that, Siptavimab is an agent which was really put forward, and this is a much greater potency compared to palivizumab, about 5 to 10 times more potent than palivizumab, and it was trialed in healthy preterm infants over a number of years in 18 countries, and some really interesting findings, and importantly some important learnings came from this. These are the Kaplan-Meier plots that came from that trial, and it shows in 2 different doses of this monoclonal protection against RSV-A, but no protection against RSV-B. And so in finding this, with overall no significant reduction in medically attended RSV, investigators went back to that and they identified a sequence change only of 2 amino acids in the epitope that led to a loss of neutralization, really highlighting that we're dealing with RNA viruses and mutations are likely to occur and completely change the efficacy of some of the agents we're looking at. But not all has been lost in the monoclonal space. Nirsevimab has been published this year, so this is now a long-acting monoclonal antibody directed against the fusion protein, and a clinical trial looking at RSV-associated lower respiratory tract infection out to 150 days in healthy late preterm and term infants showed a significant reduction in medically attended RSV associated lower respiratory tract infection. And this is subsequently gone on to seek registration. It's been registered in Europe, and other applications are coming forward to regulators such as the TGA in Australia to register this agent as a monoclonal for use in RSV protection in young children. What about vaccines? Well, a number of vaccines have made it through early phase 1 and 2 trials, but none in this early period of 1990 to 2000 made it to the phase 3 trials. In the last 5 years, we've seen a real rush of candidates coming forward. I'm going to describe a couple of those to you. The first one I want to describe to you is the Novavax vaccine that was delivered to pregnant women. Pregnant women in a trial in South Africa and in the US. So this is a RSV fusion protein nanoparticle vaccine and was delivered between 28 weeks and 30 weeks gestation. And they had a rather complicated endpoint of RSV associated medically significant lower respiratory tract infection up to 90 days. And importantly, you needed to be RSV positive. You need to have a lower respiratory tract manifestation and have evidence of medical significance. This trial missed its primary outcome by an absolute whisker. So a 39% reduction in medically attended lower respiratory tract infection, but with their endpoint crossing 0. And so the trial was deemed a failure. Now, I think it highlights that actually maternal vaccination is likely to be beneficial, but in missing the primary outcome has set this vaccine back. Other maternal strategies have been set back as well. GSK had a candidate that was in phase 3 program that was enrolling up until this year. We are enrolling at this site into the GSK program, but a safety signal has sparked the suspension of this program as well. So unfortunately, we do not have a maternal vaccine candidate that is coming forward at the moment, although one is in trial produced by another manufacturer. I'm going to jump into the elderly quickly because there's been some really interesting results coming from the elderly program. Novavax, which I mentioned in the pregnancy space, did a number of clinical trials years ago looking for a effective vaccine in the elderly, and unfortunately did not meet its primary pre-specified efficacy outcomes. But 2 trials reported only in the last couple of weeks have demonstrated that this is likely to be possible. So the GSK study, which reported in October that they had actually had a successful candidate. So this is a pre-fusion protein adjuvanted with AS01, 1 dose given to those over the age of 60 with a top-line efficacy of 82%. It's been underpowered to assess severe outcomes, even though the company has reported those, but relatively small numbers in this trial. So 12,000 in each group, the active group and the placebo group, with 7 breakthrough infections in the vaccinated group compared to 40 in the placebo group, with an overall vaccine efficacy of 82%, only measured in a single season. Pfizer has had a similar program. They have a bivalent vaccine, and 1 dose of 120 micrograms of this has been associated with an efficacy of 66%, also underpowered to assess endpoints, but importantly a different strategy using an RSV-A and an RSV-B vaccine with efficacy demonstrated for both of those. So in summary, after years of disappointment, actually it's been an incredibly exciting period in the RSV world. We've now got demonstrated monoclonals that are effective in infants, and importantly that registration is being sought for those. We've got vaccines that look like they're safe and effective in the adults. However, that is only over a single year duration, so we are going to have to monitor that over that time. But I do think we need to just pause. Molecular evolution and duration of protection are key uncertainties, and that is going to be critical knowledge in designing effective RSV prevention strategies. In my last couple of minutes, I really want to jump into some of the antivirals because there's some exciting developments in this space. Most people believe RSV is a self-limiting illness, and it's right. And for most infants and also for most adults, it is a self-limiting illness that requires no treatment. It usually takes between 7 and 12 days to overcome an RSV illness. And up until this point, there's only one registered antiviral for this purpose. But actually the quality of data looking at the efficacy of ribavirin for RSV has been pretty scant. But there are a number of emerging vaccine targets, often looking at the fusion proteins, but also looking at some of the internal RSV proteins that are capable of being targeted. F protein inhibitors have been explored, and although a number have been discontinued in trials, there are two that I wanted to talk about. One is prisutrevir and one is zeresavir. And importantly, there are other agents such as polymerase inhibitors and replicase inhibitors that are emerging as well. The first study I wanted to highlight, which is on prisutrevir, which is a drug which is one of those fusion inhibitors which did not show efficacy in 4 phase 2b studies, but I include in here because it highlights some of the challenges of this space. So 4 adult studies in stem cell transplant or lung transplant recipients, or just hospitalized elderly patients with a largely virological driven endpoint. Despite adequate plasma exposures, none of the pre-specified primary endpoints were reached. But if you look into the data, it highlights the emergence of resistance on therapy with this agent. A small number of isolates had resistance prior to use of this drug, significantly increasing in both stem cell transplant recipient populations on therapy, highlighting that we are dealing with RNA viruses and there is a risk of this. And the last drug I wanted to touch on is one called zeresavir, which is really has been developed over the last couple of years by Chinese manufacturers, and only last month has shown to be effective in a phase 3 double-blind randomized controlled trial in young children. Given for 5 days, twice daily, compared to placebo, there was a significant reduction in the bronchiolitis score and viral load. So we haven't seen these data in their entirety. They've been only released by press release and at the International RSV Symposium in Belfast. So we look forward to reviewing these data in their entirety. I do want to come back to this slide though. We're talking about antivirals, but actually it's likely the immune response to RSV is as relevant to the pathogenesis as the direct impact of the virus. And so whether opportunities for disease prevention involve immune modulation in the future is something that needs to be explored. So in summary, RSV is self-limiting in most children and adults, but there is a role for antivirals, particularly those at severe risk of severe disease. Viral evolution will remain a challenge in the RSV space and one we're going to have to combat. And targeted immunomodulation may provide opportunities. So my last slide, it is actually an exciting field to be in the RSV space after years of disappointment. I think COVID has provided many insights and has been the true disruptor that has been unraveling some of the aspects of the epidemiology, transmission and susceptibility to RSV that we needed. I think the field of antiviral therapeutics and vaccinology will only step forward in leaps and bounds, and pathogens such as RSV will benefit from that. And whether sustained vaccine-induced protection is possible remains to be demonstrated with this pathogen, and that will really inform what our programs look like going forward. And with that, I'll stop sharing my slides and very happy to take questions at the end.
Can you hear me, Chris?
I can now.
Yeah. I'll go, if anyone has any questions, just put them in the chat box. Otherwise, I might just ask, I've got lots of questions, I'll just try and limit it to one or two to let others ask a question. I was using, as an adult physician, a quarter of cap intusions are clear. Is that with bacterial co-infection, Chris, or is that?
Sorry, I just struggled to hear that, Andrew. Was it a question about co-infection?
Correct. So that you said 1/4 of paediatric cap is due to RSV.
Yeah.
That by itself or with bacterial co-infection?
So that's by itself. So doing a population attributable fraction in that case control study, the proportion of disease that was due to something like mycoplasma was about 10 to 15%, pneumococcus about 10%. Now, clearly there is overlap with these pathogens, but actually RSV in children is a primary cause of pneumonia in a significant size. We have to say that some of our diagnostics, those are limited, so they are estimates. I expect there are adult populations where RSV is a primary cause of pneumonia as well. How much co-infection contributes to that remains to be determined.
I guess my other question, maybe there's not a clear answer, but the recent study, I can't remember the one you cited, which showed an 87% roughly efficacy. So, and there wasn't really a difference in severe disease. So when you've been on a target, how much evidence do you need before you said it's only being tested over one season, for example? Like, do we repeat this? Do the same subjects get followed for a year or so, or how does it work in practice?
So, yeah, firstly, we need demonstration of efficacy and safety. So that is step one. We can't progress with that. One, we need to have better estimates of the burden of disease, because really the cost effectiveness will be the threshold for implementing on the NIP. Cost effectiveness is likely to be determined by one, efficacy, duration of protection, because this is probably not something you're going to do every year. So if it's disappeared by season 2, the likelihood we can have sustained benefits over a long period of time is absent. So the data I would be looking to in this period of time is duration of protection, impact against severe disease, and particularly how does it affect the elderly population, the group that are most likely to come into hospital? How well does it work in that population, the severe elderly, as opposed to the study population, which were really over the age of 60? Those are clear elements that we need to determine. We may not have efficacy data for many years, but also understanding from some of the phase 1 and phase 2 data, the duration of antibody levels, and comparing that to a correlate of protection would be really important.
Thanks, Chris.